Good afternoon, everyone, and you're very welcome to the session. My name is Darren Stevens, and I'm Senior Vice President and Commercial Head with Qure. And it's great to be here today to join you for this session and to moderate the session. Today we aim to bring some real-life experiences of AI adoption from various different clinical settings from across the UK. I think we're all in agreement that AI has captured our collective imagination. However, amidst all of the buzz and the excitement surrounding AI, it's crucial that we navigate through the hype and critically examine the real-world implications and challenges associated with its implementation. We've brought together a distinguished panel of industry trailblazers who not only witnessed the potential of AI firsthand, but have also successfully integrated into clinical pathways. Throughout the session, we will share their invaluable experiences, vision, and strategies for effectively leveraging AI in clinical practice. Furthermore, they will also emphasize the importance of collaboration between healthcare professionals and technology experts to ensure the successful integration of AI into clinical workflows. We encourage you to ask questions, engage in thought-provoking discussions, and challenge the assumptions surrounding AI. By the end of the session, we hope you will leave with more clarity on how effectively you can leverage AI and navigate the complex landscape of AI integration in clinical practice. My job is to keep everybody on time, and hopefully we'll achieve that successfully. And we look forward to hearing your contributions and interactions at the end of the session. So to introduce the first speaker, I would like to welcome Dr. Rhidian Bramley, who's consultant radiologist at the University NHS Trust, specialising in oncology imaging, healthcare management and informatics. With a remarkable career, Dr. Rhidian currently holds multiple key positions, including clinical lead of diagnostics, digital and innovation at the Greater Manchester Cancer Alliance. He is also the clinical lead for Greater Manchester PACS programme. Very welcome.
Thank you, Darren. Thank you very much for inviting me here today. It's a real pleasure. Just for declarations, I'd just like to say I've got no affiliations with any of our partners in this project. But what I'm going to talk about today is this project. It's a key project for Manchester, and this is where we're rolling out chest X-ray AI across the whole of the population. So this is 3 million people. This is 13 hospitals, 7 major acute trusts. Okay? Should have practiced. Right. So why are we being so bold? So I've got a role as well as diagnostic lead with the Cancer Alliance. So we're looking at this strategically from a cancer perspective. So we know lung cancer is the biggest cause of cancer death. We know that if we look across the world, developed countries in Europe, UK is right down towards the bottom. We have got some of the worst outcomes for cancer. We also know what that's due to. It's because we diagnose lung cancer much later than most of these other countries. So the long-term plan set targets, say we've got to diagnose ideally 75% of patients when they're early stage disease when we can treat it. Okay, that if we do that across all cancers, we'll save about 55,000 lives a year. Huge difference. Okay, now in Manchester we've got a big strategy, early diagnosis strategy to try and do this. This forms part of that strategy. That's why you can think big on this. So we also know that lung cancer is the only disease to have its own GIRF, getting it right first time report. Okay, this report sets out, along with the National Lung Optimisation Pathway, really tight timescales for turning around some of our investigations, chest X-rays and CT. And the reason for that, and it details it out, is because days make a difference on this pathway. Every day that you're delaying diagnosing that patient, their 5-year survival goes down. Okay, and it can drop quite rapidly in this group. So the other thing is that one in the middle there, and if you're going to Google anything from this, Google HSIB, that's Healthcare Safety Investigation Insurance, HSB, chest X-ray. That will bring up this. Very good report, because chest X-ray as a test has got its limitations, then we need to be aware of that. It made 3 key recommendations. One of them is that we should be doing more to evaluate AI in the use of chest X-rays. So that's what we're doing here. One of the other recommendations is that a normal chest X-ray does not exclude lung cancer. A lot of GPs believe radiologists when they say it's normal. Okay? So the guidance is that we need to educate GPs not to just dismiss it, patient symptoms, when we have a normal chest X-ray. Now that's a difficult thing our GP leads say to get across, to GPs, and they say the best way for us to do that is for the radiologists to put it on their X-ray reports. So this was quite a difficult challenge in Manchester. I'm grateful for Anna for her support on this. We've got agreement across the whole of Manchester for the normal chest X-ray reports. We put this standard phrase on the bottom, okay? That's what we do. That's a key thing. Now, nothing really to do with AI. AI could put that on automatically. We actually use AI to audit our use of it because AI can detect the normal chest X-rays. The third recommendation, and this is really getting to the nub of it, is that we need to do more to evaluate using more CT, better use of CT in the symptomatic pathway. So what do I mean by that? So we know from the national lung screening trials that were done, chest X-ray, low-dose CT versus chest X-ray, CT is 4 times more likely to pick up a lung cancer. Now, fortunately, in the UK now, we were hearing yesterday from Professor Mark Richards that the National Screening Programme has recommended that lung screening in forms of health checks is rolled out across the UK. So if you are between 50 and 75 and a smoker and you get called up for this and have got some symptoms, you can get fast-tracked into CT. If you have that CT scan, up to 80% will be early stage 1 and 2, treatable. Your 5-year survival, at best, that's stage 1, can be up to 80% of patients can survive 5 years. If you go down the other route, which is the traditional route in the UK, the symptomatic route, that can take a lot longer. There's delays all the way along the pathway. And you also get the test, which we know misses small lung cancers. If you go down this route, only 30% of patients will be diagnosed stage 1 and 2. Your 5-year survival is about 16%. That's the difference. So the key thing, if you think about it, the test that diagnoses lung cancer is a CT scan. Everybody who gets treated for lung cancer has a CT scan. What it really is, it's just how long does it take you to get that CT scan. So what we need to know is how can we get CT scans to these patients with cancer sooner. Now the issue is we haven't got enough CT scanners. So in the UK we've got 9 CT scanners per million population. The OECD average is 26. So radiology has to ration the use of CT. Now we're quite strict on this. Of these patients here, only 2% get through to CT. So in Manchester we do 500,000 chest X-rays, about 140,000 GP X-rays. It's huge numbers. So we've got to work out how best to use this information that we've got on the CT and the chest X-ray to work out who should get a CT scan, and can we do it as fast as possible, because days mean lives. So what we're doing is that we're doing a study. We're going to do we're doing every chest X-ray prospectively across Manchester in adults. 250,000 we're doing. That'll diagnose about 1,200 lung cancers in that cohort. We're also retrospectively looked at 3,000 patients with lung cancer and looked at all the chest X-rays that they had done leading up to their cancer diagnosis. We're also presenting findings. The AI findings is decision support to the reporters to see if that makes a difference. And thirdly, we're using it to predict and prioritise patients on work lists and work out whether they should have CT. So how do those each 3 go? So the first one was actually, it's one of the major stumbling blocks for a lot of AI. It was remarkably easy for us because of the way we did it. So we deployed AI through packs. So basically Qure gave the software to Sectra to run. So Sectra just run it. So from an IG perspective, so that they're the data processors, it's the same data control as the trust. The IG was very easy. Also, the IT departments didn't have to do anything. It was just deployed in the cloud. They didn't have to do anything. There were no integrations. All they had to do was say, yes, turn it on. And we got them all to say, yes, they'll turn it on. That's the first step is shadow mode. So what happens then is it comes back. We see the priorities coming back for each of the chest X-rays, within a minute of them being done, and the findings that they have. Now, in shadow mode, the actual radiologists, the people, the radiographers reporting it, can't see that. We just use this for modelling, and we work with the departments to do that. Now, we did have one trust drop out at this stage, and you just need to be aware of this, okay, and that was the moral duty argument. Now, you can decide whether you think this is a good argument. So there's one trust that said, well, we're a bit different. We don't report any of our A&E radiographs, and we don't report any of our inpatients, okay? But now you've turned this on, we can see that some of these have got cancer. So we feel a moral duty now to report these, but we haven't got enough radiographers to do that. So we want you to turn the AI off because otherwise we've got a moral duty to do something about it. Now that's an interesting argument, isn't it? We know about 50% of cancers come through the A&E and inpatient route. So, you don't need AI to tell you that. Everyone's got a moral duty. So these are things that are useful to know. We are helping that trust, I'd like you to be pleased to know, to get through it. Right. So the second thing we said we'd do is we would provide decision support. So this is standard chest x-ray. I've done A&E, ward doctor. Look at this, typical Manchester chest. See a bit of a cough. Have they got some pneumonia or just give them some antibiotics, bronchitis? Great. Now, if we have AI that actually says, ooh, there's a little nodule up there, and it might prompt you to do a CT scan, you can see there might be some benefit there that we could diagnose these earlier. Now, when we went to the radiologists, the radiology departments, and said, right, we want to turn on this, they were all very happy for the GP radiographs. We'll do this. In radiology, we're reporting these. When we said we'll do it about the A&E ones, they said, well, we don't want anybody outside radiology to do this. Interesting. Apart from one hospital did it. And why? Can you imagine why? It's because we've got very limited CT capacity. And the management role of CT is to stop people getting CT scans. They said, well, we're worried that it might increase the CT scans we do, so we don't want anybody outside of A&E. Plus, we don't know what they're going to do. They might do something silly if they get the AI gets it wrong. Interestingly, the one trust that is doing it, Bolton, Rizwan's here, fantastic job at Bolton. They rolled it out. They're 2 years. Their A&E doctors like it, survey, they think it's great, decision support, no incidents. So the risk of something going wrong is probably very low, but that's the consideration. Now, they might be right. The key question is does it actually help us pick up lung cancers? So we've been surveying, asking, having regular meetings with everyone saying, does AI pick up things that you're missing? And the answer is, no, it doesn't. Now, do we believe them? I mean, is a radiologist or radiographer going to say, actually, no, I missed all these and the AI picked them up? It's difficult, isn't it? So, I look back. All the cancers that came through, which ones did the humans miss and did the AI pick them up? So I'm still doing this. So I've gone over 300 cancers, gone back. Humans are very good at picking them up. Okay, we're actually picking up about 90% of them. Okay, a lot of them aren't visible on chest x-ray, probably there, just can't see them. But we do miss them. The AI is also very good. But because the ones that are missed are really difficult to pick up, the AI is not picking up either. So what we've found so far for everything is actually, for radiologists reporting and radiographers reporting, it's probably not going to help us pick up much more. Okay? That's in radiology. That doesn't mean don't do AI. Wait for it. So the other key question is, can it help us diagnose lung cancer earlier and work out who should get the CT scans? Well, true, right, it can. So these charts at the bottom, you're probably used to these. These are days on the bottom, and this is how long it took to report each of those chest x-rays. Now, this is actually the cohort of patients that had lung cancer. So this is patients with lung cancer, and this is how long it took to report. So it's quite a lot reported quite early on, but there's big tails. Some of them are taking 2-3 weeks, in which case this cancer's growing all the time. And this is only a small part of the pathway. So we've shown just by modelling, and you can model this in lots of different ways, that if you prioritise 31% of the GP chest x-rays, you will include, that's all the cancers, because chest x-ray doesn't pick up all the cancers. If you go through that, there's a very small number of ones it will miss. The majority of those that it's not picking up is just not visible to anybody. So if you want to pick up as many as you can, 30%. So is it possible to do that? So we were the first trust we went to and said, can you do this? No extra resource, this is just the NHS. Can you do this for us? And they went to me and said, yeah, I think we can do that. So what we'll do is we'll just report that 30% first, and then we'll go back and report the rest from oldest forward. So we'll just adapt the way we do it. They did that, we looked at it, all of those with cancer, bang, day one. The national lung optimisation target pathway is you should be reporting all chest x-rays with lung cancer by day one. No one's going to achieve that, but with AI you can, if you turn AI on. It can make a big difference. That's that. A&E, we don't prioritise at the moment. So if you do it at A&E, you've also got a thing. But you have to model this because it's quite difficult within your departments. Now, unfortunately, just before we're out to roll it out everywhere, the trust that was doing this asked us to turn it off. And they asked us to turn it off for mainly they said, look, we're working off this work list. We've lost productivity. 50% loss in productivity working off this work list, where this 30% you're prioritising. And the reasons for that are, well, one, it's got the abnormal ones on it, so they take a bit longer to report. 2, they've got to look at the AI radiograph as well, but they said that's very quick. The third, and this was completely avoidable, we didn't know this, it's all about workflow. So we built the work list in PACS. We're rolling out PACS-based reporting this year, so that seemed logical, but we report in CRIS. We've got bidirectional desktop integration. But what was happening was when we reported them, when we clicked verifying CRIS, it was clearing the work list in PACS, so you had to go in and reload the work list and all that. It was an extra 30 more seconds, but it was a pain. But the managers at the hospital said, look, this is about productivity for us. This is a big thing, losing productivity, so we want to stop. We understood there was something to do, so we agreed to pause it. But that's where we are. I'll come back to that, but what I've not said, the final thing is that is just one model. Now, we can identify through this, and we're showing it, that there's obviously other groups that have a much higher chance of having lung cancer. You take a smaller percent. And we can model it and compare with, for example, lung screening and say, look, this population, quite a high risk of having CT. Let's get a direct to CT pathway, hot reporting, straight onto CT. That would make a huge difference as well, because there are delays between chest X-ray and CT. So we're doing a lot of work and health economics on that bit now, and I'll be sharing that later. So that's what I wanted to say. I'll put a summary slide. I won't go through these, but it's just in case people want to look through. I'll just leave you with a famous Peter Drucker quote that I sometimes reflect on when I'm doing this, because we know in radiology we've got very difficult challenges and everything, but the quote is about management is about doing things right, and leadership is about doing the right things. And a lot of this is about not doing what we're doing currently, but doing the right thing. So I just want to share that with you. Thank you very much. Thank you.
Just one second, Dr. Rhidian. I think we have any questions from anybody in the audience? No questions? Okay, thank you. Moving swiftly on to our second speaker, Dr. Sarim Ather. Our next speaker is highly accomplished medical professional serving as consultant radiologist and digital AI lead at Oxford University Hospital's NHS Foundation Trust. Dr. Sarim holds a PhD in neuroimaging, and you're very welcome to the session today. Thank you.
Thank you for inviting me, and thank you for everybody who's turned up to listen to me. Like I was introduced, I'm a consultant radiologist working in Oxford. I'm also the AI and digital lead at Oxford University Hospitals for radiology. I've been working with AI for the last 6 or 7 years. I've sort of seen it evolve from an idea to something which is now tangible, being used for patient benefit. I'll be talking about a study which has been funded by Qure.ai via an NHS award. I'll just be going through. I know a lot of you guys have been interested in AI and know about the challenges we're facing in radiology, but I'll just give a brief background as to where we are at the moment, what the motivation is about getting AI in, what we have seen as the barriers for implementation so far, and then talk through how we're trying to overcome these barriers through the evidence that we're generating through the NHS study. So medical imaging is ubiquitous throughout pretty much every secondary care pathway and primary care pathway. Primary care pathway, both acute and planned care, whether that's cancer, whether that's trauma. If you come into A&E, almost 2/3 of the patients end up having some sort of scan. If you're unfortunate enough to be admitted, you'll have 5 scans during your stay. And the reason is that having early access to imaging can reduce how many hospital admissions you have. It can reduce the amount of unnecessary surgery that we do, and that has resulted in an exponential increase in medical imaging that we're doing, despite the shortage of scanners and radiologists that we have. And this is just highlighting the shortage of radiologists within the NHS that we have, and that has real patient impact in terms of the time it takes to turn studies around, and the care that we provide for our patients. In the emergency department, our pathway is such that a patient comes in, has their scan. The CT scans generally tend to be reported by radiologists, and the turnaround time, depending on the time of the day and who's available, what type of scan it is, can take up to 1 hour to 2 hours to turn the reports around. For X-rays, the ED physicians interpret them, as we discussed earlier. But for the CT scan, generally, the physicians tend to wait for the CT scan report before they can action it, unless it's a really obvious abnormality that they can spot. And how can AI sort of disrupt this pathway? AI has been around in radiology in a different guise for several decades. Initially as CAD, but doesn't really have much acceptance. More recent technology advances in computer vision technology have led to this new increase in the number of AI products that we have available at the moment. And the breakthrough came in 2012 with deep learning, which was a step change in the accuracy of image interpretation by machine learning. And initially this was on general imaging, so cats and dogs, can you differentiate them properly using computer vision? It reached human level around 2015 and then has since supposedly gotten better. And as a result, the number of publications related to CAD have gone down, but there's been an exponential increase in the number of publications related to machine learning. But we still don't have widespread implementation of AI. We're still at the trial phase at the moment. And there are several hurdles, several bumps along the road to implementation, right from the beginning, choosing the right type of problem to solve, making sure that you have the correct data to solve that problem, making sure that you've used the right sort of evaluation to evaluate the algorithm, deploying it responsibly, making sure that it fits into the workflow, and then once it's been deployed, how do you keep updating the models to make sure that it's happening correctly? And there's several sort of tests that we can do to the evaluation. We can look at algorithm accuracy through statistical measures. We can see if they're heat maps, to measure up to what the experts think in things like radiotherapy planning. We can assess the impact on clinicians, on their speed and accuracy, on their confidence. Does the AI UI and UX fit in nicely to attain usability and acceptability? We can look at patient-level outcomes. We can look at hospital-level outcomes in terms of report turnaround times and ED flow. And I think all of these questions need to be answered to make sure that we can adopt AI safely and securely. And the NHS set up a fund to help accelerate some of this work through the NHS XAI fund. Initially, it was allocated 140 million. Not quite all of that was allocated. I think we allocated close to 115 million. But majority of that went to diagnostic imaging. And one such award was secured by Qure alongside our other collaborators for evaluation of their CT head algorithm. So this algorithm is able to detect some acute abnormalities on CT heads, including intracranial hemorrhage, midline shift and mass effect, infarcts, and cranial fractures. And from an ED perspective, those are things that can mean, does the patient need to come in, do they need to be referred to somebody else, or can you safely start doing discharge planning? Because as radiologists and radiographers, we know vast majority of scans that we do, CT head scans that we do, don't have any acute abnormalities. Might not be quite normal because of the population that we scan, but they don't have any acute abnormalities. So we don't have to keep the patients in, and we can safely triage them and start discharge planning, or initiate their treatment if there is an acute abnormality. And we split the study into, so in terms of evaluation, we've split our evaluation into two parts. Firstly, we want to look at the impact of giving the algorithm to the clinicians and seeing how they find it. So in terms of usability, acceptability, do they get better? We've created a multi-case, multi-reader study where they'll have 150 scans to look at, including at least 10 each of the pathologies that we've talked about. So it'll be a sort of 60-90 split with 60 normals and 90 abnormal cases, and we'll see how well giving them the algorithm improves their practice. We'll have a mixture of junior radiologists, ED physicians, and radiographers looking at these scans. And then we'll be looking at the impact of AI on their performance, on their diagnostic performance. The data would be coming from NCME, which is a center for intelligent medical imaging, which brings together a network of hospitals. So we'll be getting 150 anonymized CT scans from there. They'll be selected based on the initial radiology reports, but we're going to have 2 neuroradiologists then reviewing the scans to establish the ground truth. They will then be uploaded onto a cloud platform where readers from 4 different hospitals can review the scans and provide their input. Initially, they will be given these scans to look at by themselves with no AI output, so we'll be measuring the performance unaided. Then they will have a 4-week washout period, and the scans will be randomized, but they'll also be given the AI overlay and an AI score from the Qure algorithm. We'll also ask qualitative information about how they found using the AI, and also things around adoption. Because any doctors are busy, is this something else that they want to take on as part of their day-to-day practice, or would they rather stay away from it? And who in that pathway is best placed to use the algorithm? Is it the radiographer taking the image? Is it the fact that you're not able to scan up, to triage the scans for urgent reporting by radiologists? Or is it the ED physician by giving them this AI output? So we're taking the opposite approach to Manchester. We are letting our ED doctors have access to the images. And then alongside that, we're also doing a prospective study across 4 hospitals where we'll be using the Qure algorithm to prioritize scans across four different hospitals, and then seeing if that has an impact on report turnaround times. And we'll also be looking at patient-level outcomes in terms of length of stay and time to referral. Our primary objective is to see whether you can turn acute reports around quicker, but obviously that then pushes all your normal scans down the list. So what impact does that have on your ED workflow? Because at the end of the day, we want, from an ED perspective, we want to get patients in and out as soon as possible. So we're looking at both what's happening with the acute scans, but also what's happening with the non-acute scans, and actually giving people telling them that there's no acute abnormality. Does that speed up their reporting? Are they spending less time looking at scans? What's happening in hours? What's happening out of hours? And the trusts that we have are quite varied. So we've got some big teaching hospitals, we've got smaller hospitals as well, which outsource all their scans out of hours. How does that impact that workflow? And we're employing a step-wedge design, so there'll be a pre-implementation phase and a post-implementation phase at each site. So we'll be able to capture that data to see how much of an impact it's having. It's a pretty huge study. We'll have almost 17,000 patients we'll be looking at over 12 months. So I think we'll be able to answer these questions quite well. We're mainly focusing we are exclusively focusing on ED patients and adult patients. There are some technical exclusion criteria which I won't go into. But one of the other things that we want to look at is how often does AI fail to process scans? Because the risk is, if the AI is very narrow focused, for example, it can't process scans from patients who had surgery before, then those scans are being triaged as non-critical, even though they might have an abnormality on there. So how do you handle those scans? Do they get to the bottom of the pile? Do they get somewhere in between? Or do you still look at them as a prioritized thing? So that's another thing that we want to be looking at. Just to go into our protocol overview, every patient who'll be coming into the trial will have the scan processed by the Qure algorithm. If there is a discrepancy between what the algorithm says versus what the radiologist has said, that all those scans will be reviewed independently. Depending on the outcome, then the ED physicians will act upon the findings, and we'll be able to measure what impact on the patient pathway the implementation has. And hopefully that will help us answer a lot of the questions a lot of the barriers that we talked about in terms of clinical validation, in terms of accuracy, in terms of how people find the workflow integration. And at the end of the day, like, is it worth the investment? Is it worth investing both our time and effort in evaluating the tool, but also for healthcare systems to adopt it? Because I think that's a big unanswered question. And I think from a healthcare system point of view, we need to make sure that as a limited resource, we are focusing on the right things. And hopefully this will help answer that question. Just like to thank all the collaborators from the different sites and Qure.ai for inviting me, and I'm happy to take any questions.
Thank you.
Thank you very much. Does anybody any questions for Dr. Sarim? Okay, thank you very much. Our next speaker is Dr. Neelan Das. Dr. Das is a consultant vascular interventional radiologist at East Kent Hospital's University NHS Foundation Trust. He specialises in minimally invasive image-guided procedures in both the veins and arteries of the body. AI lead in East Kent, and you're very welcome. Thank you very much.
Thanks a lot.
Thank you.
Some of you may have seen parts of this talk yesterday, but essentially I've made it into one talk, and I'm going to do a deeper dive into the sort of barriers to adoption rather than focusing on the data that we've collected so far. But I was really impressed to see Rhidian's talk, because he just reminds me of a guy on a skateboard, like skating on really smooth concrete, and I feel like I've been skating on gravel for the last 4 or 5 years. But you know, there's real positive elements that have come out of it, and I'm going to talk about my 5-step program to implement an AI solution, but it's all a bit tongue-in-cheek, so hopefully this will work. Step 1, we've talked about that. What's the need? First of all, this is going to be like an instruction manual. I think it's going to be easier for me and for others going forward when you got the right PACS provider. But if you don't have the right PACS provider, it's quite tricky, and there's going to be quite a lot of people without the right PACS provider probably still. And I think a lot of DGHs that are going to be doing this alone, as opposed to being a big teaching hospital. We're a big DGH, but we function like a really tiny cottage hospital sometimes. So, not that cottage hospitals are substandard, but essentially before the pandemic, no films were reported by the radiologists apart from the GP ones. During the pandemic, the instruction went out to report them all. And now we have about 1,400 that are more than 10 days old outstanding from ED. And that's, you know, between March 22 and May 23. So, although somehow the management did do an audit, said there's no clinical risk to that. Does that make sense? No, it doesn't. That all leads to burnout in the departments, because we know that there's a radiology shortage. So there is a need. And here's a highlight one, because a patient had TB after an RTA. They came in, it was missed by ED. The rest of the family got TB. That's not good. So we did I'm going backwards and forwards in time here, because actually I first contacted Qure in April 18. December 2018. But now I'm talking about an audit we did last year. Out of 50 abnormal X-rays, which were correctly, 50 abnormal X-rays looked at, 40 of them were correctly interpreted by ED, but 10 of them were misinterpreted by ED. And 5 had consolidation, 1 had a pneumothorax, 1 a pneumomediastinum, and surgical emphysema, which you should be able to feel, but it was missed. So, and there's a lung mass, which comes down to Rhidian's little talk. So there's quite a significant clinical risk, and it leads to inefficiency, and I've talked about radiologists feeling burnt out because they're always being interrupted. Now, step 2, get people round a table and fist bump each other. IT director, information governance director, procurement representative, interested radiologists and clinicians, and I'll add to that now a new role of CCIO, Chief Clinical Information Officer, maybe a Chief Analytical Officer. There's a lot of chiefs around. So get them all around the table if you can. our IT director at the time said, I can't test every single AI provider out there. And I said, but there's only 2. But still, we tested one because we came to a unanimous decision that we would use Qure because they had a lot of evidence even at that time. When I say a lot, they'd peer-reviewed at least and published in The Lancet, and they're deployed in multiple sites across the globe. So it gave me some confidence that we'd get somewhere. Procurement said, you need to get on the G-Cloud framework. And that was in 2019, in April. And the deadline closed for that year in May. And it only came out once a year. So clearly that was missed. And so it really became tough. But, as I said, we got there. We chose Qure. And a lot of people have talked about Qure, and I've talked already about why we chose them. But they've got a lot of chest x-rays under their belt. I wanted to improve the immediacy of the reports to ED. I wanted to create work lists of normal and abnormal workflow for radiologists. Potentially, I thought we could just leave the normals to one side or do a 10% audit of them if we're really confident in the software. And hopefully that will just mean the radiologist can, concentrate on the abnormals. Now, I'm an interventional radiologist, so I don't even report chest x-rays, so the radiologists might hate me for this, and Rhidian's already said that there's been a loss of productivity focusing on the abnormals, but we'll see how that goes in my trust. What's the next step? So I feel, at this point in time in the landscape, we should all, if we're deploying a radiology AI solution, we should actually do our own little validation. So we did it on 1,000 chest x-rays. As COVID hit, of course, that delayed us. Radio silence from procurement, from IT. But once the dust settled, we did get our deployment done. And essentially, there was a version 2 and a version 3. But to cut a long story short, the version 3 revalidation, if you like. And remember, this is an exercise in a pre-deployment setting. It's not a research study. So we're being pragmatic here, but out of 993 chest x-rays, out of the 1,040 that we sent, 47 were unable to be interpreted due to poor imaging quality, and we have to do a deeper dive as to exactly what that was. This is only in the last month or two. 587 were abnormal, according to the radiologists, and 586 were correctly interpreted as abnormal. 406 were normal according to the humans, and 264 were normal according to the computer. Giving you this sensitivity and specificity for just abnormal versus normal, not each individual pathology, although Qure is now, I think, class 2B for 23 pathologies. So then, when we did the first pre-deployment exercise in September 2020, just when the dust was settling from COVID, I then presented it to the Clinical Executive Meeting Group in January 2021. So this is what I want everyone to know, what the steps are if you're going to do this yourself. You're going to have to present it to someone. You have to do a business case, because if you're not lucky to be grant funded, you're going to have to fund this from your own department. That can take a few months, because at the end of the day, if you're already reporting the chest x-rays, why are you going to spend money on an AI solution? If you're not reporting them, you're not spending money on radiologists, so why are you going to buy an AI solution? So there's a little dichotomy, but we have to push the clinical, what you believe is the clinical improvement factor, and then the long-term cost savings and that side of the business case. And actually, if you can prove, and I think we will prove it here, that if you can improve radiology turnaround and workflow efficiencies, so radiologists concentrate on other things, then I think you can write a good business case, which we did. But procurement, fortunately now, SBS, which are shared business services, NHS shared business services, have started bringing out a kind of framework for AI providers to jump onto. So a lot of the due diligence is done. So Google NHS SBS. There seems to be internal competition in the NHS. There's supply chain, there's SBS, various people, whoever, it doesn't matter to me. But SBS are one that have, several providers on there, chest x-ray, brain. The idea is that they'll have done. Any provider has to answer sort of 20 to 40 questions, a minimal kind of due diligence. Well, it's actually quite a significant due diligence. And you can then be reassured that a lot of that work has been done already, so you can then either decide to do a direct award to a company on that framework, or you can do your own mini tender. Our trust did a direct award. When you do a direct award, your procurement have to do a ratification document, and that in itself can take a few months, even though it might just take a couple of minutes to write. So you also do a DPIA, of course, that's important. And actually that was the easiest bit, because our DPIA guy is fantastic, really pragmatic. First of all, when we did the first study, he said, this is all anonymous, I'm not worried. When it actually came to doing real patients, he goes, this is fine because it's like teleradiology and we're keeping it within the trusted firewall. When we went to cloud, he said, everyone's moving to cloud, so that's not a problem. It's all, tickety-boo. So he was really good, and I was really grateful to him. Phil Elliott is his name. But genuinely, I'm making jokes like it's a wedding speech, but this kind of thing is really important, because you can get bogged down in this kind of bureaucracy, and it can really have an impact. When you come out the other side, it's very good, but as radiologists, you can lose the will to live because you feel like you're doing it on your own. But you do radiology engagement sessions, and Qure, again, one of the reasons, any company you work with, just make sure they're supportive on helping you. It's in their interest to produce all these kind of leaflets and things to, just support you to engage with the rest of your colleagues and the department the clinical department you might be, serving. IT integration, I think our IT department were great, but, all departments are pressurized, so, and these are things that are low down their agenda still. There's not like a government target they have to hit, so, you've got to make friends with them. It's the age-old thing about how to win friends and influence them. And if you've got the right people on the side, you'll get somewhere. But the IT integration includes, setting up the server, doing some operational testing, making sure that the time-limited window that the company has, that your IT department has given them, you've got 24-hour access to our trust firewall, doesn't suddenly close, and then you have to reopen it, and then no one answers the email to reopen it, and you then have to get involved as a consultant to get them to reopen it, and then you forgot the person that you're talking to 3 months ago because it was 3 months ago, and then you try and search your emails, blah, blah, blah. We all know that. So you need a project manager. And if you've got that, you can go live. And that's what we did on the 1st of May. And I actually think you then do the post-deployment surveillance. I talked about that yesterday, but just briefly speaking, the other thing is, because we had a really crappy PACS before, we couldn't integrate it well enough to be able to send all the A&E films. So we had to just integrate it with 2 X-ray machines in the ED department. But now we're going to what I think is a reasonable PACS. We'll be able to do it all A&E films from the middle of June. And that'll be really good. So in 2 weeks, we collected about 120 HS X-rays that did have a radiology report attached to it. And we've got some false negatives, but they're really small amount. And actually, I've looked through them because now we've got a diversity of reporters in these, junior radiologists, radiographers, and consultant radiologists. We've got to be now sort of quite carefully re-audit about who the reporters were, because some of those ground truths are not actually ground truths. Who's really right. But sensitivity of roughly 95%, I think that's close to 97% on these very small numbers. And specificity of around 78%. And that specificity we have to actually pay attention to, I think. And we've got to look at whether extra CT scans are being done because things are being overcalled. We've made an instruction that don't do extra CTs at the moment. Don't interrupt the radiologist because you want to double check the AI. But that day probably would come. So we've got to tease out how much is that really going to... So this is the thing about real life deployment. Anyway, it spotted the rib fractures here. And real life deployment. This PDF and Qure know this. They've switched this PDF function off for temporarily till a bug's fixed in it, but clearly it spots the rib fractures, but in the actual textual report it generates, it doesn't mention a rib fracture. So we said switch it off, and there's just a little bug in the system at the time, and I think it's already been rectified, where bony findings weren't being put in for some reason. But it's just something you pick up, because ED was saying to me, oh, the report, it doesn't mention the rib fractures, but it's there on the x-ray, so what do I do? So these things are, just things you learn as you go along. A couple of false positives. This is an example. It's absolutely normal chest x-ray. For some reason, the software has defined it as abnormal and said there's a nodule, but we as a group couldn't find it. Maybe that thing in the top left, but it hasn't ringed it. So, these things you'll just come across. I don't think they're critical. No critical misses so far. There seem to be a few missed hiatus hernias, but the program is not designed to interpret hiatus hernia. So Qure tell me that they're now working on that. There's a hiatus hernia. And the last point, the next steps are really to do a deeper, broader evaluation with many more films. We'll also do some sort of manual audit, which we're planning, a satisfaction survey, ad hoc, feedback from the A&E docs so far. It seems to be helpful, but it's only 2 WhatsApps. 5-step program. Identify the problem statement. Carefully select your AI vendor, because now there's quite a few of them. Contracting, requisite approvals, procurement really is a headache. Take paracetamol. Scoping, deployment, project management. Please do get a project manager, and I'm sure everyone has those in the departments, but please, if you're in the management side, please give your radiologist adequate time of a project manager if it's not dedicated. Don't let the radiologist struggle around, because this is in everyone's interest. And buy-in and adoption. I'll go back to that. Buy-in and adoption. I think that if you do this properly, engage your radiologist, engage your A&E staff, if you're doing A&E, whoever the clinicians are. Do it cautiously, baby steps, take everyone with you, then they'll use it in the longer term. If it's something that's just dropped in, from above because someone got an NHSX award and it's not really got taken through properly, people might lose faith quite quickly, and we're seeing that actually in our trust with some other things. And just be careful how you do bring it into the trust. Just get the key people really on board, and that's with everything, isn't it? But we're there, and we're now ascending. So there you go. That's the end.
Thank you. Thank you, Dr. Das. Any questions for Dr. Das? No. Oh, one? Yeah.
Yeah. Yeah, I don't think it's that rigorous. I mean, without doing myself down. I mean, basically, it's the bureaucratic hurdle that took a long time. 1,000 chest x-rays is not a lot. So you can do Huh? Oh, the question was, do you think the rigor, there's not much time to do anything right now, but do you think the rigor that with which I've done this project is replicable everywhere? And I said, I don't think it's that much rigor actually what we did. It's just the rigor is in the paperwork, if you like. That I call it paperwork. Everything apart from clinical to me is paperwork. But 1,000 chest x-rays is not a big deal to put through an AI piece of software. Getting 2 radiologists then to look through it independently, yeah, that's a bit harder. You could use, to be pragmatic, as more and more trusts do this, you could just say, well, East Kent did it, so we don't need to do that. You could say, I'm going to use Qure's own 2 independent radiologists and trust that, and because it's good enough for me to do a deployment, and then I'm just going to monitor it in deployment very carefully without having to do the full, pre-deployment exercise. But I would say do a small pre-deployment, just so that you're not getting, they say it's 99%, it's not coming out at 40%, something like that. Enough to give you confidence that, well, let's do it in real life. And I think that's fine. And the other two documents, by the way, there are two documents called DCB 0129 and DCB 0160. That is basically about clinical safety and risk hazard logs. DCB 0129 is what a company should provide about what the risks are, and 0160 is your return answer about how they'll mitigate it, and your return about whether you agree and what the risks are. And that can be an alien concept to a lot of people.
Thank you. Any other questions? Good. Thank you very much. So moving on to our final speaker, and hopefully I do your introduction justice. But last but not least, it's Dr. Nick Woznitza, and he represents InHealth Reporting as a consultant radiographer.
Thank you very much.
Thank you.
Following on from Neelan is A, always a tough crowd, and B, with The Simpsons, it's got to be, hi everybody, hi Dr. Nick. Anyway, light-hearted, 10 minutes, you're all after lunch. So AI in clinical practice, where are we? As I said, I have several roles. I am a clinical advisor within health reporting, and that's sort of where I'm speaking of today. And so we're talking about efficiency, effectiveness, we're talking about adoption, we're talking about chest x-rays, we're talking about AI, seeing the difference between Greater Manchester saying we can't turn it on to ED, Sarim and the Oxford trial saying, well, we're only going to focus on ED and we're going to give it to the ED clinicians. This is really where we sit at the moment. We are in this sort of soup of, we know we need to do things better. Why? Because patients are suffering. I think the things around the efficiency targets, even the 18% triage, all of these things is, at the end of that x-ray as a patient, many patients don't know that a test being done is divorced from a test being reported and then being communicated back to their doctor. Some patients are more aware, some patients are healthcare professionals themselves, a lot of patients aren't. And so at the point an examination is finished, be it a CT head, be it an ultrasound, be it a chest x-ray, that's Schrodinger's patient. They are both well and sick. They are both normal or need further care. And it's not just them. You have a test done, especially for a chest x-ray. So I love chest x-rays. I can see Anna in the audience. She also loves chest x-rays. Chest x-rays are the best test. And I'm not saying they're the best test for all circumstances, but they are my favourite test. Don't have a favourite child, I have a favourite x-ray. But in terms of that, it's what, 3 minutes? So I'm a radiographer. The longest part of a chest x-ray is IDing the patient and getting them changed. Taking a chest x-ray in an outpatient setting in a relatively compliant patient with English as a first language is in seconds. And then they're told, go back to your doctor in 2 weeks. And they're like, but you know the answer. And the radiographer may know the answer. The radiographer should be able to preliminarily evaluate an x-ray. But that's not the point to the patient, who thinks that my test is done. It's like a blood test, isn't it? It's routine, it's taken minutes. Blood analyzers run it straight away. Why aren't you telling me? Is there something bad? Is there something good? Oh, I'm reassured, it's absolutely fine. I don't need to go back to the doctor, they told me to go in 2 weeks. Oh, that's got to be normal then, doesn't it? And so this drive for efficiency is always part of, well, so what? It's the so what question about that patient is both normal and abnormal, and not only until the x-ray is reported, but until someone has communicated that finding to the patient themselves. We know immediate reporting works. National Optimal Lung Pathway calls for, as possible, reported chest x-ray before patient leaves, if not Rhidian's within 24 hours, CT scan within 3 days. Randomised trial evidence out of Homerton a few years ago found that by the patient walking past the CT scanner and not having same-day CT, doubled the time to diagnosis of lung cancer. But how do we do it? England, 2 million chest x-rays from GPs every year. Can we hot report 2 million chest x-rays? No. Because it just doesn't work. We've got all these different scenarios. The ethical issue of not flagging abnormal A&E chest x-rays. It's these things that we are at a critical turning point, and we have to make sure that whatever we do, the patient is the person who gets the benefit from this. And so how is reducing turnaround time using an AI triage tool effective? So if we say that your normal x-rays can be deprioritized, now for that patient, it's an all or nothing. right? You are either normal or not. It's not 95% triaged, it's not 95% accurate. It's a 0 or 1. It's all or nothing. But how then are you using your limited population level resource to identify those patients who benefit most from an immediate report? And that's where AI comes in. I think Rhidian's full graph of the lung cancers diagnosed, if you can get them most 0 to 1, I think your ED one was slightly longer, but these are the areas where it's triaging appropriately. But also, if you start thinking, well, the efficiency bounce back of actually it's taking longer to do it because when you hit verify, all of these things are operational, but the science is there. Prioritising those who benefit most is effective. We can help our patients. But we also have to remember thankfully, the vast majority of our patients have a normal X-ray. If with a normal chest X-ray, triaged as normal by AI, and a templated report, so if we all have, well, I'd say most of us probably report chest X-rays or interest in chest X-rays. I have a templated report that I speak into my digital dictation service, and it comes up. I might tailor it to the clinical question, like Qure pneumothorax, but I've got a normal report. But I also have review areas. I have my feedback both from Rake, which is a nodule detection, it's a QA tool, but also my peer review feedback, which is, Nick, look at ribs. But to be fair, if you start looking at the evidence, everyone misses ribs. Not everyone, Anna, but everyone misses ribs. And the errors in radiology have been around since radiologies themselves, and we haven't really changed them a whole lot. So if you've got review areas, you've got a normal text template within your report, and you have the safety net of you've done your assessment, you've done your review areas, the AI has given you your second set of double review. Templating the report is this part of the maximising the efficiency. So you prioritise the abnormal, they always take longer to report. And we have the secondary capture saying that this is probably normal. And we have a template within for verification. I'm not advocating autonomous reporting, it's illegal in the UK at the moment, and we are far way off of it. But by matching all the pieces together of, I think it's normal, AI says it's normal, we are now at a point where instead of...
This is a delegate announcement. GE sessions are about to recommence. Please make your way to your sessions.
Excellent. I think that's my 5-minute warning, isn't it? So we have the templated report within there, and is that the efficiency that we need? And efficiency is often spun around time, money, workforce. But we need to see what's efficient and effective for our patients, and it's the same word. So can we pre-populate normal reports? I think so. And I think in terms of the maturity of evidence and the impact on practice, if we prioritise the abnormal ones which take longer to report, or as when I get back to my NHS role, find the X-rays that have been left on a Thursday afternoon, coming back, then Anna's laughing at me, coming back on a Monday morning, and they're still there, which will take longer, but actually then bringing back that time with a normal templated report for a normal chest X-ray. Prioritisation needs to happen. We are a limited resource. We need to use these effectively. So AI, effective, efficient in terms of safety nets, in terms of templated reporting, but crucially, prioritisation for those patients who benefit most from our reports. Thank you very much.
Thank you. We might have a minute for any quick questions if anybody wants to ask any questions before we leave. No, thank you very much, Dr. Nick.
Oh, Anna.
Have we got somebody, have we?
Hi, I'm Anna Sharman. I'm a radiologist in Manchester. So I agree that we need to prioritise the abnormal ones in terms of, picking up lung cancer, getting them to a CT scanner quicker. My concern with all of this is the normals just keep going down and down and down on the list. And it is important to tell the patient it's normal. And so you have got a patient at the end of that normal film as well. And that patient wants to know that it's normal because they're worrying just as much as the abnormal ones because they don't know that they've been put into it's a normal category because nobody tells them that. Yep. So it's a bit like, I do obviously lots of lung cancer. I've set up lung cancer screening in Manchester. So I'm all about lung cancer, that's fine. But and all the lung cancer scans sort of get to the top of the pile in terms of CT scans. And my ILD colleague is very concerned that all the ILD stuff actually is getting further and further down the list, but actually often your outcome from UIP pattern of pulmonary fibrosis is worse than lung cancer, but yet we just want to put it at the bottom of the pile. So it's a little bit like the normal chest x-ray. For that patient, it is as important to know the results as whether it's abnormal.
Yeah, and I often agree with Anna because she's brilliant, but I couldn't absolutely agree more. But part of this is around, well, if we are prioritising those who are abnormal, hopefully, especially for a primary care setting, you're looking at the abnormalities about sort of between 15 and 40%, depending on your prevalence and what you deem to be abnormal. You're prioritising a relatively small subset. It doesn't mean that you have then extra capacity to report it, but if you then match the, I'm going to abnormal it, but then actually have a templated report for your normal, because even with the best digital dictation in the world, I don't blame my Aussie accent anymore, I think it's almost gone. But it doesn't always pull up all of my things. And if you're starting to say, well, actually, for expert readers, a normal chest x-ray, you know that within about 3 seconds. You then stick into type 2 thinking to go, all right, hilum, diaphragm, ribs, Nick, and double check it, to then check the AI, and it's already there. You've then gone from saying a minute, because then you need to go, next field, signature, whatever, verify. If you can actually shorten the time of your normals, which fortunately are most of our patients, hopefully it blends out that you've done the both. Because absolutely agree, patients need to know their results.